Hi guys, it's me, Professor D, and welcome back to my channel. On this video, I'm going to be covering end-of-life care. If you haven't done so already, guys, please be sure to like and subscribe below. Press that red button so you'll be notified every time a new video is released. All right, guys, without any further ado, let's get started. Which intervention is compatible with the goals of end-of-life care? A, administering a flu shot. B, preventing the client with COPD from smoking. C, performing passive range of motion exercises to prevent contractures. Or D, permitting the client with diabetes mellitus to have a serving of ice cream. And the correct answer is D, permitting that client that has diabetes to have a serving of ice cream. Why? When it comes to end-of-life care, when it comes to palliative hospice care, our goal has gone from trying to save the patient to knowing that whatever it is that's going on with the patient, it's terminal. That patient is going to die. So our focus changes to comfort. Our focus changes to increasing the quality of life versus the quantity of life. So let's look at our wrong choices. A, administering a flu shot. Well, a flu shot, that's painful. We're giving them a painful injection to prevent the flu, but this patient's dying and it's terminal. There is nothing that can be done to save this patient, right? And end-of-life care, palliative care, hospice care is all about what? Promoting comfort. So A is incorrect. B, preventing them from smoking. If that smoking is what's bringing them comfort in their last days, we're going to let them do that. So I know we always think no smoking, no smoking, no smoking. But that's when we're trying to what? That's when we're trying to make sure that patient stays healthy. We're trying to increase the quantity of their life. But with this patient where it's terminal, we just want them to be happy, want them to be comforted. So that's wrong. C, doing range of motion exercises to prevent contractures. Well, let me tell you something. This is the second best choice, because we could do range of muscle exercises because maybe the contractions, if the patient might have pain and we want to prevent that, that's something else. But we have a much better answer. Letting the patient with diabetes have ice cream. What are we worried about? That their blood sugar is going to get too high? We want them to be comforted, right? We want them to be happy because they are on the way out the door. So we want to increase the quality of their life and bring anything that promotes comfort. So D is the correct answer choice. Which of the following represents a major philosophy of the hospice concept? A, improving the quality of life for a patient with terminal illness. B, assisting the family member of a terminal illness. B, assisting the family of a terminally ill client to grieve more efficiently. C, ensuring that a terminally ill client is never alone. Or D, removing the stigma of death. And you guys should all have this correct because I gave you the answer when I was talking about the first question. And it's 1, improving the quality of life. We're no longer concerned with the longevity, with the quantity of life. We care more about the quality of life, just bringing comfort and peace and happiness to that patient. And that's exactly what hospice care is all about. Which clinical manifestation alerts you to the fact that the terminally ill client is approaching death? A, the client calls one son by another son's name. B, the client's extremities are cold and mottled. C, the client has asked to see a minister. Or D, the client's pain is increasing. And the correct answer is B, the client's extremities are cold and mottled. What happens is as that patient starts to die, their circulation decreases significantly. And so their skin might start to feel cold, and that's from the decreased circulation. The color may be bluish or grayish, and it may be mottled, and that's just because of the decreased circulation. It really lets you know that death is imminent. Okay, let's look at our wrong choices. You have 1, the client calls one son by another son's name. Well, that's confusion. Confusion can happen in many things, such as infection, right? So that doesn't necessarily mean that the patient's currently dying. Choice C, them asking to see a minister. That may mean the patient themselves they're preparing for death when it comes, but it doesn't mean that they're dying at the moment. And then choice D, the client's pain is increasing. As you guys know, there's pain in so many different conditions, not just death, but seeing that patient's extremities become cold, become mottled, yes, that is an absolute sign that death is imminent in the terminally ill patient. Next question. Which action constitutes active euthanasia? A, increasing opioid-based pain medication to achieve adequate pain relief. B, discontinuing treatment of bacterial pneumonia with antibiotics. C, allowing only oral fluids for a confused client. Or D, limiting wound care to only once per day. And the correct answer is B, discontinuing treatment of bacterial pneumonia with antibiotics. So what is active euthanasia? Active euthanasia is purposefully going out of your way to shorten someone's lifespan, right? So a patient who has pneumonia, then taking their antibiotics away, you're purposely shortening their lifespan. What about our other choices? A, increasing opioid-based pain medication to achieve adequate pain relief. You're not shortening their life. You're increasing the opioids, not to make the heart stop, not to make them stop breathing, but so that they get enough, sufficient, adequate pain relief. That's a good thing. So that's not the answer. Choice C, allowing only oral fluids for a confused client. Well, guess why? Because if we, let's say we give that patient an IV, they're confused. What do you think they're going to do? Try to rip it out, right? So that's a confused patient. So that's not intentionally shortening their life. And choice D, limiting wound care to only once per day. And this is usually protocol. We don't like changing wounds more than once per day because we want to promote wound healing, right? And so we want to promote that wound to start to close up. And in order to allow that, you have to actually leave that wound covered for a certain amount of time. You don't want to keep ripping off that Band-Aid, right? So there's nothing wrong with that. We want to promote wound healing. So the only one that you'd actually be going out of your way to shortening someone's life is taking away the antibiotics for someone who has pneumonia. When should abnormal symptoms in a dying client be treated? A, when they're serious and may lead to death. B, when they affect the client's rest or comfort. C, when they do not interfere with religious beliefs. Or D, when they disturb the family. And the correct answer is B, when they affect the client's rest or comfort. Why? Remember, it's all about the patient and it's all about promoting comfort. So we're going to treat something when it gets in the way of their comfort. Okay? So let's look at choice A, when it's serious and may lead to death. They're dying already. So that can't be the answer. Choice C, when they do not interfere with religious beliefs. Well, that's a good thing. We don't want anything to interfere with the patient's religious beliefs. Why? We want to promote comfort. Are you guys starting to see a pattern here? Choice D, when they disturb the family. Listen, our focus is on the patient, not on the family. I'm sorry. So the correct answer is going to be B, when they affect the client's rest or comfort. So for example, if a patient's got nausea and vomiting, we're going to treat that because you think that patient's going to be comfortable if they're puking all over the place? No. So we're going to treat disorder or process that's going on with the patient only when it interferes with their comfort. The spouse of a person remaining at home during a terminal illness is concerned because the dying client does not want to eat. What is your best response? A, if he says he's not hungry, let him know that food's available when he wants it, but don't insist that he eat. 2, a feeding tube can be placed in the nose to provide important nutrients. 3, force him to eat even if he doesn't feel hungry or he will die sooner. 4, he's getting all the nutrients he needs from his IV. And the correct answer is A, guys. We want to promote comfort again. You're going to tell them, don't force the client. Just let them know if they don't want to eat now, let them know that food is available if they are hungry or when they want to eat. Remember, the patient that's dying, their metabolism slows down significantly. And so their needs for nutrients decrease significantly. So you have to teach the patient's family that, or they'll think the patient's going to starve to death. And that's just not the case. Their nutritional needs slow down and they decrease significantly when the patient's dying. Choice 2, feeding tube can be placed. A feeding tube isn't necessary. Choice 3, force. Let me stop. You do not force that client who's terminally ill to eat. There's no reason for that. Okay, we want to promote comfort. In choice D, he's getting all the nutrients he needs from the IV. That doesn't matter. This client is terminally ill. They are dying. So at this point, we just want them to be comforted. So if they want to eat, feed them. And if not, let them know food's available when they're ready. In providing palliative care to a client with a terminal illness, under which conditions should you consider insertion of an indwelling urinary catheter? And I expect everyone to get this one correct. A, when the client's taking medications affecting the output. B, when the client's output drops below 500 mLs per day. C, when the client would be more comfortable. Or D, when the client is incontinent. And you guessed it, C, when the client would be more comfortable, because at this stage of the game, it's all about what? Comfort, promoting comfort for the client. Okay, guys, we're down to our last question. The client tells you that even though it's been 4 months since her sister's death from a ruptured aneurysm, the client finds herself crying uncontrollably several times a week. The client is afraid she's losing her mind. What is your best response? A, most people get on with their lives within a few months. You should see a grief counselor. B, whenever you start to cry, distract yourself from your thoughts of your sister and try to sing. C, you should not cry. I'm sure your sister's in a better place now. Or D, your feelings are completely normal and may continue for a long time. And I'll give you a moment to think of your answer. And the correct answer is D, your feelings are completely normal and may continue for a long time. So guys, everyone grieves at different rates, okay? You're not going to teach the client's family member to just try to not to think about it. You want them to express their emotions, because that is how that they will be able to move on with their lives. They have to go through that grieving process. There's nothing wrong with them, and you have to let them know that this is normal and that those feelings may continue for quite some time. Okay, remember, we always want patients to express their feelings and to be open about it. Guys, I hope you found this video helpful. I promise there will be more to come on this subject matter. Again, if you haven't done so already, be sure to like and subscribe below. And guys, if you want to support me in this channel, please share my videos. Anyone you know that would benefit from it, share it. Thank you so much, and I'll see you next time.